For me, the thing that improves clinical usability the most was being able to connect the esophageal balloon to the mechanical ventilator and seeing the airway pressure tracing and the esophageal pressure tracing synchronized on one monitor. Because before, when we started out, we actually connected the esophageal balloon to blood pressure transducers, and then we had to connect it to the screen that shows blood pressure and heartbeats, and then you have a different screen showing airway pressure, and they weren't synchronized, and one unit was different from the other. You had to do calculations always during static conditions. So when we were able to get it on one screen, that really improved the usability quite a lot. I think the larger esophageal balloons that are integrated with feeding tubes have a few distinct advantages. One of them is, in my experience, they're easier to position. It's usually very easy to position an nasogastric feeding catheter. Your patients will need one anyway in almost all of the cases. And then they usually have the radiological marker, which makes it much easier to confirm that they are positioned at the right level. So this is improved quite a lot. And because the balloons are larger, they have a larger range of filling volumes that result in acceptable ratios when you're doing the hold maneuver. So both of these things are easier with the larger catheters. I think there's a few distinct groups in which we use the catheters the most. The first group being patients on severe respiratory failure that we end up with trying to titrate to be lung protective, and then we find that even at the optimized settings, driving pressure is still high, plateau pressure is still high, and we want to make sure that the driving pressure that we're measuring without the esophageal balloon is actually due to stiffness of the lungs. Because if it's stiffness of the lungs, then maybe we need to try additional techniques. But if the driving pressure is actually used mostly to move the chest wall, then we would be willing to accept higher plateau pressure and higher airway driving pressure. And being able to make the distinction between the chest wall and the lungs can be really crucial in these patients that are very difficult to get in lung protective ventilation. If you already get them in a lung protective range without the esophageal balloon, then maybe in that patient it is not required. A second category in which they can be very useful is when patients are on pressure support or another supported mode of ventilation, and you want to make sure that they're synchronous with the ventilator, and you can use esophageal pressure to see that their patient's effort is in unison with the ventilator support. And patients that are most likely to not be in unison are, for instance, patients with COPD, obstructive lung disease. So these patients are really beneficial in the spontaneous phase of their critical illness to have these measurements. And they can also really help us when we have patients that are very difficult to wean, and we can use the esophageal pressure measurement to monitor their respiratory muscle activity, make sure they're using their respiratory muscles while they're on ventilation, but also not using it too much. And we can use it to get very reliable maximal pressure measurements to have a good indication of the total capacity of their respiratory muscles. I think these patient groups are the ones that I tend to use esophageal pressure the most. I think that an important clinical trigger for me to insert the catheter is a patient with respiratory failure that I cannot get in lung protective ranges with the usual monitoring that we have. So driving pressures remain high, for instance. That will be a trigger for me to check whether the driving pressure is high due to the lung stiffness or the chest wall. If I suspect asynchrony, which is something you can sometimes even observe when you look at your patient, that's for me a trigger. Or if I don't understand why a patient is difficult to ventilate or why he's so asynchronous, I feel that having the additional information of the esophageal pressure can sometimes show me surprising reasons of what's happening. So if it's something I totally don't understand, I tend to use it as well, the esophageal pressure monitoring. I think it really depends on the patient. Some patients in the beginning of the ICU admission, everything's doing fine and it's pretty easy to get lung protective ventilation, or you don't worry about their respiratory effort, and then something deteriorates later on and you place the catheter. In a few selected groups, we tend to place them immediately. If we already know that they are having severe ARDS, for instance, the chances that we can use the esophageal pressure is very likely, so we might insert the catheter as the first nasogastric feeding catheter immediately. And then in some patients, we switch to the esophageal balloon when they fail their first weaning trial. We suspect it might be difficult weaning, and then we might insert the catheter at the later phase in the ICU admission. So during controlled ventilation, I tend to target an end expiratory transpulmonary pressure between 0 and 2. I think before we were glad when it was between 0 and 6, but later data and later analysis of existing data has suggested that staying closer to 0 is probably more beneficial to your patient. So currently between 0 and 2. Implementing transpulmonary and esophageal pressure management in our team was quite a journey. It is not something that happened within 1 week. And what we did, which worked pretty well, was start with a small team that really gets into the measurement, that understands what's going on, and then very quickly try to get other team members involved. Get your ventilation practitioners involved, get the ICU nurses involved, give a lot of training, and especially new people coming in, immediately train them on how to use them, how to interpret the measurements, and then slowly we would build it out where more people would be able to do the measurements and more people would be able to train different people. And I think that getting more layers involved early on really helped us to implement this new technique into our clinical practice. I think the most important research question that we still have to answer is whether using the monitoring indeed improves patient outcomes. Currently, we have a very strong physiological rationale and observational data that supports the use of esophageal pressure measurement in your patients, but data showing that it improves outcome is still scarce. This is something that is always very difficult to obtain in monitoring tools, but in the end, using the monitoring tool will not make your patient better. It's making better decisions because of the monitoring tool that will treat your patient. So this is research that is very difficult to conduct, but I think it is the last piece of evidence that we really need to start bringing this to all ICUs and all patients, and it's something that's being worked on currently.